Good morning, everybody. It's my great pleasure this morning to introduce Dr. Dana Fuhrman as our Grand Round speaker. Dana is an associate professor in both the Department of Critical Care Medicine and Pediatrics here at Children's Hospital of Pittsburgh, and we're truly fortunate in having one of the very few dual board certified pediatric intensivists and nephrologists in the country here at Children's. She completed her pediatric nephrology fellowship at the University of Rochester in 2013, where she received a Master of Science in Clinical Investigation and subsequently completed a pediatric critical care medicine fellowship here at Children's Hospital of Pittsburgh in 2015. She joined the Department of Critical Care and the Nephrology Division in Pediatrics. She co-directs the CRT program at UPMC Children's Hospital of Pittsburgh with Julia Bayer, and really has led a number of clinical innovations in that role. And if that isn't enough to keep her busy, she's also a very active clinical researcher. And in 2019, she received an NIDDK funded K23 to study methods to predict and prevent kidney disease in young adults with a congenital heart disease. Her research interests are really focused on the use of renal functional reserve and urinary biomarkers for the early detection and prevention of acute kidney injury. So we look forward to hearing from Dana about some of her exciting work today and are grateful for her to be here this morning.
Thank you so much, Jackie, and thank you so much for the organizers for giving me a chance to present today my work. I hope my title got you excited about what we're going to talk about today. So without further ado, we'll get started. Just my potential disclosures, my funding, and I do some speaking for Medscape, unrelated to what I'm going to talk about today. So our objectives for the next 45 minutes or so is to talk about, and my goal is for everyone to leave here recognizing that AKI is a common syndrome that is associated with serious short and long-term complications, really understanding how pediatricians and those who take care of children are truly leading the way in critical care nephrology, which is quite exciting, and identifying how novel and readily available biomarkers can be used in the early identification of AKI, and describe how the early recognition of AKI can certainly address the burden of AKI. And I also importantly want to make you excited about critical care nephrology, recognizing that a lot of you listening today may be in training. I thought I'd spend just a second or two talking about my path in this. I found this a few weeks ago. This was in my medical school yearbook. And my goal when I went into medical school was to actually be a medical missionary and use my hands and really natural methods for treating people in underserved areas. And it's interesting how things certainly change, and being open to those changes is certainly key. I did a nephrology elective, kind of got forced into it a bit by my chiefs. And this is, my attempt at putting all of renal physiology in one picture. I did not prepare this for the purposes of this Grand Rounds, obviously, but really just fascinated by the physiology that goes on in the kidney, the nephron itself. We could spend our lives trying to understand it and still not quite get there. And what better place to see live physiology than working in the intensive care unit? So a lot more to that story, but where I ended up is pretty far from where I started in terms of wanting to be all natural and just hands-on. This is something I'm quite proud of. This is a really multidisciplinary effort here at Children's. This picture includes a combination of intensivists, nurse leadership, ECMO perfusionists, and specialists in plasma exchange and pheresis. And we all got together and perfected a really innovative protocol for putting children on combined ECMO, CRT, and plasma exchange. So again, pretty far from where I started, but being open to those changes, I certainly encourage the trainees in the audience to embrace those. So without further ado, we should start with talking about how we define acute kidney injury, how we currently define it. As Jackie mentioned, I started my critical care medicine training in 2013. It really was a perfect time to jump into critical care medicine and be excited about critical care nephrology because we finally had a definition for acute kidney injury. It was a long time coming. There were a number of definitions that preceded our current definition that we're called to use, which is the KDIGO criteria, or the Kidney Disease Improving Global Outcomes criteria. And what I want you to take away from this is that KDIGO is the way we currently define AKI. We have numerous hundreds of studies showing this to be validated in both children and adults. And it's the basically the definition of what constitutes stage 1 is a serum creatinine change from baseline of 1.5 to 1.9 or greater within 7 days, or greater than or equal to 0.3 within 48 hours. So an acute change in kidney function that we need to be aware of. Why do we need a standardized definition? Why did this change the landscape of what we now see in critical care nephrology that really wasn't studied much before then? It was, but unfortunately we had over hundreds of definitions in the literature and really made it very challenging to compare outcomes. Not all AKI is considered equal. I hopefully will convince you today. We need this to follow changes in kidney function. We need to standardize AKI as a hard outcome, which we have done. And we need to be able to compare outcomes across patient populations. So having a definition is absolutely paramount in that. Importantly, why do I study this? Why am I passionate about this? AKI is common, it's dangerous, it's expensive. It occurs in 20% of all hospital admissions, more than 50% of patients that come into the ICU. A huge reason of how many that I chose to pursue a career in intensive care medicine. It results in the death of more than 7 million people worldwide per year. And then septic AKI is becoming a area unto itself of research. The mortality is 3 to 5 times greater for those patients that develop AKI with sepsis when compared to those that don't. And also AKI costs money. This is data from the national inpatient sample that includes data from more than 7 million hospitalizations in our country. It includes 44 states. And for patients, when we adjust for things like comorbidities and type of hospital, the investigators found that per hospital record, the cost of each record was $2,000 more for those with AKI when compared to those that don't. This does not include patients on dialysis. When they included dialysis in that, it was about $12,000 more per record. So again, AKI costs money. And as I tell my colleagues, and we talk about in the ICU, when the kidneys aren't working, it's harder to take care of other organ systems, notably the brain, uremic toxins, inflammatory mediators, a lot to come probably on the kidney-brain interactions that are occurring there in research. As we know, heart failure, volume overload, when the kidneys aren't working, this can be impacted. The way the gut works with gut wall edema and microbiome disruptions, a lot of potential research in that area. We're learning more. Cassandra Formick, one of my nephrology colleagues, is investigating this, the effect of kidney function on the immune system. Just getting acute kidney injury can put you at risk for infection, not just infection causing acute kidney injury. Liver dysfunction, certainly with congestion, and then no secret that lung injury is impacted by volume overload and the effects of acute kidney injury. Hopefully I've convinced you it's important and it's common in adults. This is the AKI EPI study, the big cited study in adults. As you can see here, it's occurring certainly commonly in adults. This was my fellow critical care research project, which was a great opportunity to investigate. We had 8,200 individuals across all of the hospital UPMC systems who were 16 to 25 years of age, who were admitted to adult intensive care units in the area. And we were interested, they're young adults, they're pretty otherwise healthy. They're getting acute kidney injury as well in these hospitals. And we looked at factors associated with this in this study. And then importantly, why we're here today, it's common in children. The AWARE study, which is the assessment of worldwide AKI, renal angina and epidemiology study that came out looking at about 5,200 children across the world. 27% of critically ill kids develop AKI and 12% severe AKI, which we typically define as stages 2 or 3. And importantly for a lot of you listening, it's not just acute. It's not just an ICU problem. This is an older study, but a really well done study looking at the long-term risk of CKD in children who have episodes of acute kidney injury. The investigators were from British Columbia hospitals. They looked at patients 1 and 2 and 3 years after AKI. I thought great, well done study. They looked at glomerular filtration rate using DTPA scans. And they define CKD as the presence of albumin in the urine and or a GFR less than 60. They also looked at this category of at risk for chronic kidney disease, that's 60 to 90, so not quite meeting what we usually define as CKD less than 60 in a GFR, hypertension or hyperfiltration. And they looked at 126 kids, and what they found is that 10% of children with AKI in the PICU developed CKD 1 to 3 years later. 47% were in that at-risk category. So these are patients that we should be following, we should be paying attention to, and we'll talk more about that as we move forward. In coming in as a newer faculty, I was excited. You know, we have an incredible transplant program, obviously no secret here in Pittsburgh. What a great population to consider studying. This was an effort involving 3 of our prior trainees, Maitel, Anna, and Emily, all put a lot of work into this project. And then Jim Squires, Sean West, and Chris Horvat also put a lot of work into this project, really creating a database of how patients are doing after non-kidney solid organ transplants. Really interested, I talked about AKI, that acute time within 7 days after a potential injury. We define this idea of acute kidney disease. So what's that time between, as I said, CKD, we typically define after 3 months, greater than 90 days, but what's happening in between? Is that a time for potential intervention? This acute kidney disease definition, that late recovery, that 7 to 90 days post-injury. How can we define this in this patient cohort? So our objective was to evaluate the incidence and risk factors for all those things, AKI, AKD, and CKD after transplant. We looked at patients less than or equal to 18 years of age who had a non-kidney solid organ transplant here between 2011 and 2019. And then we excluded patients with a history of any kidney issues prior to transplant. We had a nice sized N, given again, we're a busy transplant center at 338. And ultimately, as I said, we defined AKI using the KDIGO criteria, and then we defined this AKD concept. It was beautifully handed to us. This concept of AKD was certainly not something that we had come up with. It was being talked about in the literature right before we were ready to start analyzing our data. Big journals came out with concrete definitions for AKI, like a wonderful gift handed to us. So we didn't have to defend our definition. We used those definitions in this study. And then we defined CKD the way it's typically defined. The group found we included 2 creatinine values at least 3 months apart. As you can imagine, this included some pretty good chart dissection. And patients had to have a GFR less than 60 when it was greater than or equal to 60 prior to their transplant. So really carefully defining CKD, which I think is a strength of this study. A little nephrology trivia. I've thrown out the word GFR a few times, or glomerular filtration rate. How do we calculate that at bedside? A lot of you probably know about the Schwartz equation. We typically, before Dr. Schwartz revised the equation, we use these K values based on age. But when you're typically defining GFR or calculating it at bedside, you just need a height, importantly a height. We love a height in creatinine or in nephrology, and a serum creatinine. And I love this, Mike Moritz will tell you our area code is 412. So if you remember that, you can plug in 0.412 and times height divided by serum creatinine and calculate your GFR. Interestingly, this equation was devised by Dr. Schwartz. Dr. Schwartz was my mentor in Rochester, off of a napkin when he was out with his friends in fellowship having wine. So these are fellowship goals that most of us will never probably reach. But that's how the Schwartz equation came to be, interestingly, from a napkin. And then here, and there was some wine involved. And then here's Dr. Schwartz at my wedding about 7 years ago after a little bit too much wine. So good things can happen over wine, I guess, is a take-home message there. So in terms of, incidence of AKI, what we found in this study and what we reported is that certainly transplant patients are getting all of these things. It's not surprising, but reporting the incidence of these things is important. Our heart patients are vulnerable, which is also not surprising. So, obviously unique risk factors on the part of our heart population in terms of cyanosis, exposures to bypass, and things that are really unavoidable, but why we really need to be careful with the kidney function of these patients as they grow in age. So for the overall patient cohort, as well as individually, and we had larger cohorts to analyze individually in the heart and liver population, AKI and AKD were associated with CKD. As you can see here, pretty strongly that association in terms of AKD. So almost 30-fold odds of developing CKD if you had a history of AKD, which is pretty impressive. So we've got a warning shot for CKD. We shouldn't be surprised when it happens. And again, AKI is not just acute. The AKI that comes and goes and never comes back is not something we worry about. It's the AKD the AKI that persists and evolves into AKD and CKD for sure. So as promised, how are pediatricians and us in pediatrics leading the way in critical care nephrology? Certainly, my colleagues and collaborators at other centers are certainly doing this. The initial studies on fluid overload that now is all over the literature, as many of you probably know, all started in pediatrics, showing the negative sequelae when our patients get fluid overloaded. This was first in peds. Studies looking at the idea of a renal angina index, which some of you may have heard about. I've been fortunate to be part of some of these studies looking at using risk criteria before coming into the ICU and using injury strata to calculate a score that will predict risk of AKI. And adult investigators have followed suit, but anything related to renal angina was certainly first in pediatrics. And then the Ninja Collaborative. Sitting here looking, I have a stuffed ninja in my office that has been gifted to me by one of my colleagues, Dr. Hamilton, and we are part of NINJA. NINJA stands for Nephrotoxic Injury Negated by Just-in-Time Action. Pretty cool name. This was devised by Stu Goldstein at Cincinnati. I take no credit for that. But in this work, basically, we identify patients that are at risk for nephrotoxin-associated AKI. Are you getting 3 or more nephrotoxins at once? Are you on an aminoglycoside for more than 3 days? And quite simply, not telling people to stop the nephrotoxic agent, because admittedly, a lot of times you can't and you shouldn't. However, are you looking at drug levels? Are you checking daily serum creatinines and having a person, not a computer alert, where we reach out and remind people to get daily serum creatinines has a major benefit. And we're part of the Ninja Collaborative. We have seen great responses at that at our center, and we're first in peds on this, and our adult colleagues have certainly followed us on this. And then a lot of work on continuous renal replacement therapy, CRT, one of my favorite things, as the fellows in our program know I love to talk about, the work that's coming in this in terms of quality improvement, having dashboards, looking at how we're actually doing this therapy well. This is first in pediatrics by far, and our adult colleagues have followed us on that, which is pretty exciting and inspiring. And so in 2021, we came together, the cohort of people really interested in pediatric critical care nephrology as this pediatric acute disease quality initiative with an overall goal to establish an evidence-based appraisal and set of recommendations to standardize care and direct future research, really bringing together experts in the field. But importantly, more importantly than bringing in the experts in the field, I will say wasn't the worst meeting ever. We met in Napa, but we brought in patients. This is Leslie Meggs, who is really nationally known for her speaking out about her experiences as a patient herself. This is her after she received a kidney from her father. And Leslie, when Leslie speaks, you're just inspired. And she went through an experience where her acute kidney injury was really unrecognized. Her sepsis was not treated, and she developed septic AKI, ultimately progressing towards needing a kidney transplant. That she is now in her mid-20s and thriving, but she came and spoke to us about her experiences, really motivating us for why we do what we do. Also, very importantly, Ray Beligno, who is the chief diversity officer at Nationwide Children's, was an absolutely pivotal part of this meeting. Ray came in, he's a pediatric nephrologist as well, certainly invested in this work, but what Ray provided us was making sure that in every area of our recommendations and our conversations, we were including diversity and inclusion in those recommendations, and brought up so many incredible points to make better what we were coming up with. Hopefully we can get Ray here for a grand round sometime soon, because he's pretty incredible. So ultimately, and we're pretty proud of, shortly after our meeting, we put together our recommendations, and I encourage you to take a look at this if anyone's interested in our consensus-based recommendations on priority activities to address acute kidney injury in children. We weren't too upset that we got that in JAMA Network Open, and we put forth 12 consensus statements, 29 research recommendations addressing the global burden of pediatric AKI. In this, we emphasize the need for a multidisciplinary approach to kidney care, the role of kidney development and sex, and the risk and outcomes of AKI. And then what I'm going to talk about in a few minutes is the use of AKI phenotypes for individualizing care. And this is a really exciting area of work. And then within that meeting, there were 11 of us who got together and talked about how we really have very little to work with. All of us are doing these things at our centers. We're a pretty small group of those of us that are this interested in pediatric critical care nephrology. And in terms of extracorporeal therapy and CRT, even smaller. There was a group about 15 years ago who tried to put together a data set surrounding the use of CRT, but it's pretty outdated now. And we were excited about bringing our data together to improve the care of patients receiving CRT. So it was a pretty small group that we started out with. We named ourselves We Rock, the Worldwide Exploration of Renal Replacement Outcomes Collaboration in Kidney Disease. You got to have a good name in these things. And we're pretty proud to report, and hopefully you're going to see more from us soon, 32 centers ended up joining this collaborative. I think they saw our excitement, 7 countries. And we now, as of yesterday, have included a total of about 1,600 patients in this collaborative. This is huge for pediatric extracorporeal therapy, huge for CRT, to have a group like this. Again, this was a lot of this decision and idea came about over us having wine in Napa. So again, nothing wrong with that in terms of great ideas can sometimes come from those experiences. And excited to report just yesterday, our first paper looking at current practices in pediatric CRT. We did a systematic review, guided multinational modified Delphi consensus study, talking about how we do CRT across the world. This includes centers in Europe as well, and just shows what a cool collaborative this is. If any of you in training are interested in critical care nephrology, to get such a response on a survey that offered no money. The survey was quite lengthy, and we really are proud of the response that we got, kind of describing what we're doing now so that we can continue to make changes. So you're all thinking, this is exciting. Great. What can we be doing now is the question. This is my older child posing here for a picture as the confused doctor. So what can we be doing now? And we're going to talk about this. Predicting when AKI is coming, stopping it before it starts. Sounds simple, but I'm going to give you ideas behind this. Diagnose AKI early and stop progression, and then therapies. This is exciting. Provide therapies to patients at risk or diagnosed with AKI. So the question is, who is at risk? One would say, do we just treat every patient like they're at risk? That would be a lot of resources. Frankly, we don't do that well. And so importantly, we need to think about who's at risk, really focus our efforts on preventing AKI in those patients, and again, preventing progression. So what are those high-risk diagnoses in children? Time and time again, we found in studies, patients with congenital heart disease, which happens to be the focus of my K23, malignancy, prematurity, more and more coming out on this. We need people doing research or working clinically in the AKI field in neonatology, organ transplantation, as I've showed you. And if you don't believe me, do a quick PubMed search. And this is just data over the last 5 years that supports that list of high-risk patients. This could go on forever, but it would get awkward with me sitting here. There are more papers than I'm even showing here. And then what are high-risk exposures? What are things that that happen to patients when they come into the hospital that put them at risk for AKI? Infection, certainly, sepsis, gotta treat sepsis, nephrotoxins, and then extracorporeal therapy exposure. Again, these are necessary things that patients need to have in order to survive. Kidneys are not going to function well if our patients don't survive. However, how can we support these patients? Let's be aware of those exposures. Once again, if you do a PubMed search, you will, over even the last 5 years, these are simply papers over those last 5 years, you will be inundated with evidence showing these high-risk exposures to be strongly associated with AKI. When should we screen children? There's a lot out there that we, in the use of biomarkers after a kidney attack, for lack of better words. What I'm very interested in is this subclinical injury, this kidney stress or kidney frailty, catching patients before something happens. Some of these things that we do are predictable. We know when we're going to expose a patient to bypass a lot of times. We know maybe when we're going to bring a patient in for chemotherapy. And so we do have some opportunities to look at patient populations, do a risk assessment, assess those patient factors, those disease factors, those event factors. A term that my mentor and I coined called renal fitness, which is the theme of my K23. I was pretty excited to sneak that into these recommendations. That idea of are there tests we can be doing, objective data we can be gathering on our patients before they're exposed to a potential nephrotoxic insult. And some of these patients, a lot of these patients are going to be standard risk. So, repeat assessments are going to be key, but then there's those patients that we're going to deem high risk, where they need comprehensive kidney evaluations, targeted maybe use of biomarkers, which I'm going to talk about, and really importantly, informing clinical trials, really enriching those trials with those high-risk patients. We have serum creatinine. Serum creatinine is great. I think we expect more of serum creatinine than it has to offer. Importantly, I think any talk that anyone's going to give you in this space is probably going to mention some limitations in it. It is inaccurate in patients with reduced muscle mass. It has limited sensitivity and specificity. This is the picture that probably every nephrology fellow sees from their attending in their first week on as a nephrology fellow, that large changes in serum creatinine, large changes in GFR are going to be reflected by very small changes in serum creatinine. This is why that 0.3 change in serum creatinine has been shown time and time again to be associated with poor outcomes. So kidneys have this functional reserve, as Jackie mentioned. This has been something I've been interested in from the start. This dysfunction, when defined as an alteration in glomerular filtration rate, only becomes evident when we lose more than 50% of our kidney mass. So you may be operating at a maximal filtration capacity, therefore look like you have a normal GFR based on serum creatinine, but in reality, you have a lack of reserve. Is there a stress test for the kidney? Something I've become very interested in. This concept of renal functional reserve, basically, again, there's this stressed form of kidney function, and can we invoke that in the lab or in studies? And so became very interested in looking if preoperative renal functional reserve can predict the development of postoperative AKI after cardiac surgery. Numerous studies since the 1980s, if you're interested, looked at taking otherwise healthy individuals, and I've done studies like this. We have no issues with recruitment because it simply involves coming in after fasting overnight. We check a resting GFR. We do this with a creatinine clearance study. We give you, and in my current study, we give you a hamburger, and then we repeat by studying another GFR after that hamburger. And we define that renal functional reserve as the change in GFR before and after the hamburger. And we found that healthy individuals with no medical problems generally have a robust change in their GFR after eating a hamburger. But what does that mean? Does that mean you're more protected when you're exposed to a kidney insult, and individuals that have a lower number are not? And up until recently, we didn't know. This is a figure I put together for my K23, and it's just basically delineating that idea. You have this kidney function that's chugging along, you get hit with some sort of kidney attack, and you're operating at this normal kidney function. As you continue to potentially have repeat events of AKI, you go into this partial recovery state. Your GFR eventually shows a decrease, but meanwhile, because of your renal functional reserve, we may not see that based on our typical test. We all know that patient that comes in, maybe gets one dose of vancomycin, and their creatinine shoots up, and you don't know why that happened. Maybe they have a decreased renal functional reserve. So I was fortunate, my mentor plugged me into this, and such a gift to collaborate with researchers in an area called Vicenza, Italy, which is close to Venice. Didn't get to travel there until years later, but offered some data in terms of some of our adult patients and looked at preoperative kidney stress test. So giving these patients the hamburger, studying GFR before and after, does this predict AKI? And basically what we found, if anyone wants to talk more about this later, because we won't get into too much detail because of time, but patients with a preoperative renal functional reserve less than or equal to 15 were almost 12 times more likely to develop AKI. And I've been studying this in young adults with congenital heart disease as part of my K23, and my results are strikingly similar, if not more significant in looking at this. So this measure of quote unquote kidney fitness, or maybe a kidney stress test, may be something you'll see in the future for these patients. Novel biomarkers, I think, important for me to mention that in this space. What about the use of novel biomarkers for diagnosing AKI early? I'm using some of these biomarkers to look at that concept of renal fitness before patients undergo bypass. A lot of these studies have looked at, after a kidney insult, changes in things like NGAL, neutrophil gelatinase associated lipocalin. This is a big one that's talked about in pediatrics. Changes in that preceding changes in creatinine, cystatin C, KIM1, and then you may see some in the literature on these biomarkers. TIMB2, IGF-BP7 are markers of cell cycle arrest. They're markers of kidney stress, and we've gotten more and more data in both kids and adults showing this to be predictive of AKI. This is a study showing the work of NGAL out of the group of from Cincinnati. These investigators looked at urine NGAL and serum creatinine, defined as you see here, immediately after PICU admission. And what they found, interestingly, is that individuals who have a rise in NGAL, even without a rise in serum creatinine, was more predicted of AKI on day 3. And so again, this warning shot that AKI is going to occur is seen with the use of NGAL, and other studies have shown this as well. we looked at in our liver transplant population, we measured NGAL, KIM1, and those cell cycle arrest biomarkers immediately post-op in these patients, looked at urine values. And as you can see here, strongly predicted when we got values at 6 hours of patients getting AKI 7 days after surgery, not quite as predicted when we got it 24 hours off, interestingly. So these values rise pretty quickly in these patients when they're predictive. And how does this compare to serum creatinine? So this is looking at, again, our patients. We published on this in Pediatric Transplantation a few years back. And looking at this, what do they do 3 days after surgery? Say patients have a negative serum creatinine, which we term negative is not meeting that serum creatinine greater than or equal to 1.5 times baseline. We define a positive NGAL, as has been done in previous studies, of greater than or equal to 150. And then the cell cycle arrest biomarkers, as they're typically defined as being positive, over 0.3. And again, not surprising here from what previous investigators have shown, although this was one of the first studies in pediatrics to do this. We found that if you had a negative serum creatinine and a negative value for cell cycle arrest biomarkers, you're pretty unlikely to get AKI. So no AKI is that blue part of the pie chart. However, if you were positive, this is a negative serum creatinine, so you've got no warning shot if you're just looking at a serum creatinine, but your TIMP2 IGFBP7 is positive, it looks quite different. Similar results when we looked at NGAL. So negative NGAL, negative serum creatinine, pretty safe place. If you're going to get AKI, it's likely going to be stage 1, and it's a pretty small percentage. However, when we just had a positive NGAL with a negative creatinine, we were seeing some AKI 3 days post-operatively. So an opportunity to potentially intervene earlier. This is just showing some data from our congenital heart patients. This is before surgery. So there's differences in healthy young adults compared to individuals with congenital heart disease. These are patients that are not stressed. They're in clinic. They're just there for follow-up visits. They're overall doing pretty well, and they have differences when compared to otherwise healthy young adults. So how can we improve our definition of AKI? There's a lot out there about adding biomarkers to our definition. I would say biomarkers should not be included in the risk assessment of all patients. I think a patient's risk profile, it's funny, I wrote this when I was a little post-call a few days ago, and I left my 2B out, and I realized I was a true Pittsburgher when I did that. Needs to be considered. So how can we, again, improve our definition of AKI? Probably we need to stop relying exclusively on these quasi-anatomical terms to describe AKI. I do like pre-renal, intrarenal, post-renal. I love a good phena. Nothing wrong with that. But taking that as our only way of evaluating AKI, looking at the whole picture, really taking a good history, as I know many of us do, but not exclusively relying on these values involved in a phena. I will say in glomerular disease, there are therapies. People have phenotyped these diseases. In AKI, we've got some work to do. Again, just defining it amongst these 3 quote unquote phenotypes, we currently have no therapy for AKI. So proposed to you, you have a patient with a low cardiac output, has an increase in serum creatinine from 0.4 to 0.8. You get a phena, it's 0.5%. The urine specific gravity is 1030. Is this patient pre-renal? Do you give them more fluid? There's little evidence that low cardiac output causes AKI due to a compromised cardiac blood flow. Instead, there's ample evidence that cardiac patients potentially in this situation are at risk of developing AKI due to venous hypertension. So a patient with quote unquote cardiorenal syndrome may absolutely be harmed by giving that pre-renal quote unquote patient more fluids. So again, thinking about the whole patient, not just these numbers, considering AKI phenotypes, more to come on this in the future, I think, because we're just putting this out there. Thinking about urine output, fluid accumulation, severity and duration as a phenotype, how patients respond to loop diuretics. I'm going to talk a bit about this furosemide stress test, and then biomarker based. So I talked about these fancy biomarkers. and then, the biomarker companies don't like this part of my talk, but we have a biomarker available to us. It's not fancy. It's urine. It's free. We just have to collect it. This is my youngest not mastering the use of the potty seat quite yet. So urine output assessment in acute kidney injury could be said to be the cheapest and the most impactful biomarker. This is data from here in Pittsburgh. My mentor, John Kellum, published on this years ago, but I think important data just showing what happens when we look at urine output. Patients with urine output defined AKI. So the definition of AKI, and I should have made this more clear, is based on the serum creatinine definition, but also based on a urine output component, changes in urine output, drops in urine output. And when you look at both and you use that in your outcome, patients do worse. We're going to predict more patients. We're going to predict more severe phenotypes for AKI when we include that. The liquid gold matters in kids too. This is data again from the AWARE trial. When we looked at patients that met that severe AKI criteria, that 15% on the left side pie chart specifically, 82% of severe AKI patients met creatinine criteria, 31% met urine output criteria, but 18, that light green component of that right-sided pie chart, with severe AKI would be missed if we only looked at serum creatinine. So studies that only include serum creatinine in the definition of AKI are certainly missing patients. We really should strive to include urine output. Critically ill children diagnosed with severe AKI require more dialysis. This is again data from the AWARE trial. And when we looked at relative risk for dialysis use compared to patients without severe AKI, with a creatinine-based definition for AKI, the relative risk of needing dialysis was 9.1, urine output only 28.2. When we combined both, the risk of needing dialysis was 100. Now, granted, the confidence intervals are massive because a small number of patients required dialysis, admittedly, but it was it definitely showed the importance of looking at our urine output in our patients. Unfortunately, we're bad at it. We're bad at it even in the ICU, although we try. This is a study, again, that came out of Pittsburgh before, at the beginning of my time as faculty, a retrospective cohort of about 15,000 patients in the ICU. Intensive urine output monitoring was defined as hourly output recording with no gaps for the first 48 hours of ICU admissions. It didn't occur in many, 26% of patients. And when it was done, it appropriately identified more AKI. And then after adjusting for age and severity of illness, intensive monitoring was associated with improved survival. And so I propose to you, really including urine output and your criteria for AKI. I think when we find patients that meet both the creatinine and the urine output criteria, that's our highest risk phenotype. I think we're going to be using this to inform clinical trials and using this for defining patients that are at risk for getting worse. The furosemide stress test is another cheap intervention, a cheap biomarker, if you will. This came about originally in 2013, and quite simply providing furosemide in a standardized way. In adults, it's usually patients that are Lasix naive, 1 milligram per kilogram of Lasix, and then looking at urine output. Those patients that have lower urine output after furosemide, time and time again, not surprisingly, we do this in the unit, maybe not in a standardized way all the time, are at risk for progression to AKI. And then again, the biomarker companies do not like these slides, but when we compared the use of the furosemide stress test giving Lasix, let's look at how well a patient pees after, did better than the fancy biomarkers. So again, kind of getting back to basics. This was looked at in children. The group in Cincinnati looked at this, and there is data to show that this could work in kids. There's more to be done in this. This was a retrospective study that looked at after giving furosemide. The group found that there was a strong predictable ability to predict AKI progression. So again, I propose to you the use of, looking at urine output patient meets criteria based on urine output and serum creatinine. We add the furosemide stress test to those patients, and we find this highest risk phenotype, these patients that don't respond to furosemide. Consider early initiation of CRT potentially in those patients, standardized kidney protection, forming clinical trials. So what's the low-hanging fruit here? Really, I ask, ensuring when transfer out of the ICU or hospital occurs, communication and document of AKI. Know the secret to making a nephrologist happy: daily weights, accurate urine output quantification. It is absolutely low-hanging fruit, and I think we can all do better. Recognizing that all patients with AKI cannot be followed by nephrologists alone. I'm going to show you some data on that. And considering a pediatric kidney health assessment. This is a really cool paper some of my collaborators put together based on there is an acute disease quality initiative group focused on adult care, mostly all adult intensivists and nephrologists. And these pediatricians came together and said, how does this apply to kids? So what should we be doing for kids in terms of how we follow them after hospitalization? All patients, and I think we strive for this, should follow up within 3 months of discharge from the hospital. And when they do, they should have a pediatric kidney health assessment. Look and find out, did this patient have AKI during their hospitalization? Make sure you check a blood pressure in those patients and follow the AAP guidelines in terms of diagnosing concern of elevated blood pressure. Patients who had a history of AKI in the hospital should have a repeat creatinine checked at some point. We don't want to find this out when they're back admitted to the hospital and their creatinine is now 3. Do a drug list review. Is this patient taking NSAIDs every day? Are they on potential nephrotoxic medications that can be, there are alternatives to, and careful attention to dosing. These are simple interventions that we can all be doing when these patients leave the hospital. What about healthcare when the patients do leave the hospital? People have interestingly looked at this. This is a group in Canada that's known for this kind of really interesting work. I think it's a retrospective cohort study. Children with AKI had a 35% higher risk of 1-year hospitalization compared to repeat hospitalization when compared to those that didn't. Increase healthcare use, and less than 25% saw a nephrologist in 5-year follow-up. They're seeing their general pediatricians, they're seeing their primary care doctors is who they're seeing, which is a great thing. I think an opportunity for those of you taking care of patients in those places for intervention. This is another study from the same group. This was a single center retrospective cohort looking at factors associated with nephrology follow-up and physician discharge. Pretty good sample size. And I think the reason I present this is, again, 18% saw a nephrologist, 95% saw a family physician, a pediatrician, or a non-nephrology specialist. So really the opportunities for catching things is in the hands of not necessarily the nephrologists. And frankly, there aren't enough nephrologists to follow all these patients. If that were to be the charge, and to ask our patients to travel to the nearest nephrologist is a pretty big ask. So even patients with severe AKI, 31% saw a nephrologist after follow-up. I would argue severe AKI would love these patients to be seen by a nephrologist. But patients who've had AKI during their hospital stay, again, should have close follow-up and have that kidney health assessment. And as I near the end here, just a plug in terms of what can we be doing to help pediatric kidneys. Please don't ignore the alerts that come up in your EHR. I know there are a number of them. We looked at this, Ellie Sharp, Jay Raker, and John Pelletier during the time when they were all trainees, all attendings now. We have an order admission set in the PICU for different medications, notably famotidine. Famotidine, not necessarily nephrotoxic, but a medication we prescribe like water a bit in the PICU. And we have dosing recommendations, but they're not based on GFR. So we hypothesized, and this was all brought about by Ellie, Jay, and John bringing this idea to me. I take no credit. We have no GFR-based dosing errors or dosing alerts for these patients. So really, let's look at this. Are we dosing patients properly based on GFR? So they took the lead on a retrospective chart review of patients admitted in just 2019. We included patients that had height, weight, and creatinine in the first 24 hours of admission. This was 766 patients. And when we looked at this, we found strikingly at the top here are those patients with the lowest GFR. In red are those patients that had a greater than or equal to 20% error from the recommended dose of famotidine based on their GFR. The errors were strikingly higher in patients with a lower GFR, not surprising. So we're not dosing these patients appropriately who have low GFRs. In patients with an admission GFR, we found specifically less than or equal to 15, or less than 50. The dosing errors were 85% versus 6% in patients with the admission GFR greater than 50. That group less than 50 is extremely vulnerable, and the errors were definitely more in the way of overdose, and you can see the percentages here. So again, our similar errors, and we chose famotidine because it's a common medication, and we wanted to see what was happening with this common medication, but it begs the question, are similar errors present for other medication? Should order sets account for GFR when dosing medications? And the group presented this at PAS a year or two back. And then we ended up finally having an alert. And this is why that number is less than 50 when you see this come up. I wanted this to be present really so I could secretly judge my intensive care colleagues during our x-ray rounds when these come up after we look at every patient's x-ray on who's ignoring GFR changes. I am kidding. We put this in place so we could make a change. Our hope is that we saw the before in terms of how we're inappropriately dosing famotidine. We put something like this in place. People are paying attention to GFR, hopefully in their medication dosing, and then hopefully we see an improvement. And so that's something that the group is likely to publish in the coming year. And then therapies. This is exciting, and I'm hoping I can come back and talk to you all about this. Hopefully there'll be a drug for AKI. We have, and where I'm approaching this right now in my research is those patients, again, that come in, have all of these hits to their kidneys that are frankly unavoidable a lot of times in the ICU, and they emerge with a normal serum creatinine, a normal blood pressure, and a normal and no proteinuria. And what is it about those patients? Can we capitalize on those patients? Is there something about the proteins that they have that potentially could be protective for other patients? And so this concept of unbreakable kidneys has really fascinated me. There was a study that came out of Pittsburgh. The lead investigators were from Pittsburgh, known as the process study. I was fortunate that all of the samples for the study are banked in one of our labs over in Oakland and got access to these samples. And we looked at these samples of these patients and found this it's a small cohort of patients that had extreme elevations in kidney stress proteins, those cell cycle arrest biomarkers, well beyond what you would use to diagnose AKI. And that cohort of patients, there was a small portion of them that didn't get AKI, but had all the same exposures as other patients. Are those patients resistant to AKI potentially? And so fortunately, more to talk about this, hopefully in future talks, in terms of things that we discover with this, because I am just now putting in a grant to study this further. But we are finding protective proteins that are specific to this patient cohort. And I want to study this specifically in our children with congenital heart disease. And how can we capitalize on these proteins and potentially develop a therapy to prevent AKI in these patients? And of course, name this nephrons of steel because we're the steel city. So in conclusion, AKI is common in children. It's associated with negative sequelae. It's necessary that those of us caring for patients prior to and after hospitalization have a knowledge of the high-risk diagnoses and exposures associated with AKI. Serum creatinine is important. It's always going to be part of our tool belt for defining AKI. It's part of our core definition. But the use of biomarkers, these novel biomarkers, because creatinine is indeed a biomarker, but these novel biomarkers has unveiled early stages in the AKI continuum and have provided an opportunity to intervene earlier. I'm hopeful that we will have NGAL available here at Children's sometime during this year. I think it will be important that we have a a structured way in which we order an NGAL. I don't think every patient should get an NGAL. The definition of AKI must include biomarkers on some level, but again, not every patient, I think, should haphazardly get a biomarker or novel biomarker checked. Studies are needed to implement the use of biomarkers to predict and give us more information and to guide these therapeutic interventions, because these therapies I'm talking about, again, shouldn't be for every patient. How do we risk stratify and choose the best patients for these interventions? And really in the now, don't forget about the cheapest biomarker, checking urine output, looking at weights, looking at fluid balance, and a simple kidney health assessment, just being aware of that when you see your patients in follow-up. So in terms of thank you, John Kellum is my research mentor. He taught me very early on, if you're not excited about your work, no one else will be. The NIH won't be, journals won't be, your colleagues will not be. So his enthusiasm is contagious, certainly spread it to me. Really importantly, my colleagues in critical care medicine, my colleagues in nephrology, my bosses, Dr. Clark and Dr. Ho, who you heard from earlier, really just support me being part of both divisions. They work so well together seamlessly. I know that is not the case at other institutions, so I'm really fortunate in that to feel supported there. I get to be the program director for the greatest critical care program in the world. These fellows keep me motivated, keep me excited. Fellows in nephrology, likewise, asking amazing questions. There's no opportunities for complacency here. The collaboratives that I get to be part of, and then of course my funding. And so I will open up for questions. Thank you.